Hi, I'm David Pariser, dermatologist from Virginia, and in the panel on clinical pearls in medical and therapeutic dermatology, I spoke about three things. One was photodynamic therapy to use for superficial squamous cell carcinoma using the 10% ALA gel and red light. The second topic was use of topical glycopyrronium cloth for treatment of hyperhidrosis of the palms. This is an area which is lacking any good medical treatments, and I've recently completed a study to show the best way to do the palms, and that is to wipe till dry with a wipe, put unocclusive cotton gloves on for 30 minutes, remove the gloves, and wash the hands thoroughly, being absolutely sure not to get any in the eyes. The third pearl that I mentioned was talking about which are the best treatments for actinic keratosis. And if you just look at the package insert results of the phase 3 trials where the same criteria was applied, and that is complete clearance of all actinic keratoses in the patient, the photodynamic therapy scored the highest and should really be considered the best field treatment for actinic keratosis. Other good field treatments include 5-FU, the new agent terminibulin, however, their efficacy was not as good as it was for photodynamic therapy.
Hi, I'm Boni Elewski, professor of dermatology at the University of Alabama in Birmingham. And we spoke today about medical dermatology tips. And I discussed treatment of brittle nails. So brittle nails are more and more common now with COVID because everyone is more concerned with hand sanitizing and hand washing, which leads to brittle nails. So how do we treat brittle nails? Well, there's not a lot of options, but you start with moisturizing. You use good moisturizers on the hands frequently. Rub it into the cuticle, rub it into the hand, rub it after you wash, or sanitize if possible. If you go online, you could find nail conditioners. There's a lot of different brands of nail conditioners that can be helpful if patients want something like that. Sometimes I think they're a little better for some patients than a moisturizer. They're targeted for the nail. Or you could use what I call the poor man's nail conditioner, which is just olive oil. You can have patients soak their fingernails in olive oil for a few minutes every day and leave the olive oil on when they go to sleep, and maybe even put a white cotton glove on to hold the olive oil in. The next point was to biotin or not to biotin. Should you give these patients biotin? Well, there's not a lot of evidence that biotin really helps, yet it can mess up your lab results for patients if you have a thyroid problem or you're having a thyroid check. It doesn't affect the thyroid itself, but it affects the laboratory interpretation and may point to hyperthyroidism in a patient who's euthyroid. So caution should be given in patients on biotin who want to get a thyroid test.
I'm Dr. Ted Rosen, professor of dermatology at Baylor College of Medicine in Houston, Texas. And my colleague is...
I'm Brian Berman, emeritus professor at the University of Miami and also in private practice in Miami.
So we were part of the medical dermatology, clinical therapeutics, diagnostic tips and pearls. The first one I talked about was the use of dupilumab. Oh my God, it's used for things other than atopic dermatitis, off-label, and it's a really, really good drug for Haley.
I talked about chemoprevention and the use of nicotinamide for preventing not only the development of squamous cell carcinoma, but also just routine actinic keratoses. It's a relatively benign therapy.
And then I also talked about the red, angry, or burning scrotum. Do you have any problems with that, Brian?
No, that's your specialty.
Okay. So a lot of things have been proposed useful for that, but none of them really work in my hands. But there is a new therapy for which there was a very good publication. I've tried it now on several patients, and it actually worked. And that's indomethacin, an oldie but goodie drug, 50 milligrams 3 times a day. Be careful about headaches and gastric irritation, but it actually worked. Brian, back to you.
Another tip on the area of actinic keratoses, terminibulin is a new FDA-approved treatment that's once a day for 5 days. But as many of the field therapies have gotten approved by the FDA, it's technically approved for a 25 square centimeter area. Now, no one in clinical medicine ever treats actinic keratosis just in a small area like that. So my tip was that we actually looked at how far we can push the treatment with one of those little sachets, one of those little packets for the treatment of actinic keratosis, and one of those 250 milligram packets, we were able to measure digitally over 300 square centimeters, which makes it a practical use for the treatment.
Another pearl that I talked about was what to do about psoriasis when it's precipitated by checkpoint inhibitors. Lots of things you could use, of course, treat it like regular psoriasis, but it turns out acitretin, which I don't consider usually a first-line drug, works incredibly well, and I showed a case that I treated that way. In standard doses, actually very low dose, 10 to 25 milligrams a day.
And the whole reason we treat actinic keratosis is really to try to avoid the development of squamous cell carcinoma. And I presented a case of the use of actinibolin, not for the treatment of AK, but actually for the treatment of squamous cell carcinoma in situ in the periungual area, a difficult area to treat. And also I go over the mechanism of action, why it would work for squamous cell carcinoma. And indeed, it did work in a very recalcitrant form of in situ squamous cell